Hope you all find this instructive and useful. So let's see if we can get the technology to work.
And whilst you're doing that, I'm going to mute myself and close my camera.
Okay, so there we go. So thanks very much for joining us today. I have been given the task of talking about fertility and endometriosis. And as Tao said, I'm Cheryl Dunlop. I thought I'd tell you, first of all, really what my role is and why I'm giving this talk to you today. So I'm a senior registrar in obstetrics and gynecology at the Royal Infirmary in Edinburgh, but I'm also a subspecialist trainee in something called reproductive medicine. So that means I've extended my training to do even more training in this field called reproductive medicine. And that involves a lot of things, but really the bulk of that is to do with fertility and IVF. Alongside that, a few years ago now, I completed a PhD in fertility preservation, and that is something that's becoming a bit more well known about in the endometriosis field, and I will touch on that later on in the talk. And finally, as part of my subspecialist trainee role, I do attend the endometriosis multidisciplinary team meeting at Edinburgh Royal Infirmary, and also the endometriosis clinics there, really to try, and there's a couple of the infertility doctors who go there to try and give our advice and opinion and really give a proper team effort towards decision making for patients with endometriosis. So let's start with, what do we know about how endometriosis affects fertility? Well, we know that there's an association between endometriosis and fertility. We know that if we look at everybody who's born female with infertility, up to 50% of them are going to have endometriosis. And actually, it's not that uncommon that a couple come to the infertility clinic, we do a scan and we see an endometrioma, which they were never aware of before on the scan. So we do see this very frequently, and we know of that close association between the two things. We also know that if you have endometriosis, it can take you longer to conceive, and that probably is even more so if you've got more significant severe disease, so stage 3, stage 4. That's what I said about more advanced endometriosis, or usually they've got more problems than if you've got minimal or mild disease. And to be really simplistic about it, and I don't mean you to suck eggs, but you need an egg. Hopefully that's a good quality egg. You need sperm, hopefully of good quality, and you need them to meet for fertilization. And if you're trying to conceive naturally, they meet in the tube of the sort of between the uterus and the ovary. So they meet in this sort of third along bit of the tube. That's where the fertilization happens. The embryo develops, and then the embryo hopefully will roll down the tube and into the cavity of the womb, where it implants in the lining of the womb. That's what we hope to happen. And we think that endometriosis probably has effects on most of those aspects, obviously not in the sperm quality, but on most of all the other aspects. But as you are probably already aware, lots of things in endometriosis are not fully understood, and fertility and endometriosis is one of those things. But there's likely many reasons why endometriosis leads to infertility. Some of those may be to do with scarring. So we know that when you have severe endometriosis, there's lots of scarring that can happen around the reproductive organs. We know that endometriosis is an inflammatory disease, so that can affect how easy it is to get pregnant. And obviously there's lots of hormones, especially if we're giving you hormones for a treatment, that can be involved and can affect fertility. And as I said, it can probably affect most of the aspects of natural conception, so eggs, the tubes, the uterus, how the embryo implants. So here's a diagram of the uterus and the tubes and ovaries. And if we think about endometriosis within the ovary itself, so an endometrioma, it's a space-occupying lesion. It takes up space within the ovary, and therefore, logically, what it does is removes space for healthy tissue. And so we know that endometriomas seem to affect what's called your ovarian reserve, so your egg reserve, how many eggs are left in the ovary. So if you have an endometrioma, you will have a lower ovarian reserve, and we know that for certain. But there's probably also an inflammatory effect, and we do wonder whether there might be an effect on egg quality and not just on egg quantity. As I said, scarring can have an effect, and one of the most vulnerable places for scarring in the reproductive organs are the tubes. So if you have any scarring around the tubes, that can block them, and obviously if they're blocked, then the eggs cannot meet the sperm. And then the other thing is that if there's an inflammatory process going on within the tube, that can affect how well that embryo rolls down the tube and into the uterus. As I said, there likely is effect on implantation of the embryo. So even when the embryo gets to the uterus, there may be a problem with due to the inflammation of it implanting properly. And also if you have a blocked tube, If that fills with fluid, and the fluid then trickles back down into the cavity, that can affect how well an embryo can implant. That can be detrimental to an embryo implantation. We know that lots of people with endometriosis have painful sex, and if you can't have sex, then it's going to be very difficult to get pregnant in the first place. And also, again, if you've got quite severe scar tissue, sometimes the ends of the tubes are not close to where the ovaries are, or the ovaries are buried, or the end of the tube is buried. So an egg can't physically get into a tube in order for the sperm to meet it. And that's just probably some of the ways that we logically and we know that that endometriosis can affect fertility. So one of the main questions we're asked by people with endometriosis is, can I conceive naturally even if I have endometriosis? And the short answer is absolutely yes. And please do try to conceive naturally if you can. And we know that most women will try to conceive naturally, and many of those women or people born with endometriosis will be able to conceive naturally. But that is especially if they have mild disease. So if you imagine if you have a few spots of superficial peritoneal endometriosis, hopefully that's not going to have caused scarring and any impact on the ovarian reserve, and you're more likely to be able to get pregnant naturally. Whereas if you've got more severe disease and things are stuck down and there's lots of pain involved with having sex, etc., that is going to be more difficult for you. But please do remember that endometriosis may not be the only reason that you're not conceiving, and so we shouldn't blame it entirely before excluding other causes. Okay, so it may be the reason, but we have to remember the other causes where people can struggle to conceive. So that might be to do with age. We know that as we get older, we have fewer eggs and fewer good quality eggs. Some people are born with a lower egg reserve for whatever reason, and so they go through an earlier menopause. Some people have problems with ovulation that are nothing to do with endometriosis. And obviously sperm quality is also important, which will have not related at all to whether you have endometriosis or not. And we should check that if you're having problems conceiving and not just assume that's down to the endometriosis. What I thought we'd look at next is how endometriosis treatment affects fertility. Okay, so first of all, we're going to look at medical management. And as I'm sure you all know, medical management is often contraceptive. So the whole point of it is to try and suppress your hormones, and that as a side effect means that you don't release an egg, for example, or the lining of the womb can't get thick enough for you to have an embryo implant. But we also know that all of those treatments should be reversible. And sometimes there is a bit of a lag, especially in the more potent medications such as a GnRH agonist and these injections we can give to suppress your ovaries. There can sometimes be a bit of a lag in your hormones returning to what they should have been, but they are reversible. It just, as I said, sometimes it takes a bit more time than others, depending what treatment you've been on. The other consideration when you're on medical treatment for endometriosis is that some of the medications, and I'm thinking more along the lines of the non-hormonal ones, so things like gabapentin, amitriptyline, it's not that they're completely not advised in pregnancy, but we might prefer you not to be on them or to be on lower doses in pregnancy. So that's something to consider before you even think about conceiving. But what we do know is that having medical management doesn't improve your chances of natural conception. So anything that we give you, we can't improve how likely it is you're going to conceive or not naturally. On the flip side, it also doesn't negatively affect your fertility. So you don't need to be worried about taking these medications. It's not going to permanently affect your fertility. It's just for a temporary, reversible length of time, going to be a contraceptive for the most part. The one rule in where medical management can be helpful is if you've had surgery and you start medical treatment to try and reduce recurrence or increase in size of an endometrioma before we then go on to do fertility treatment as a sort of stopgap measure so that the ovaries, etc., are in their best possible state before we start fertility treatment. But again, that is it's an individual decision about what you would like to do. And what about surgery? Well, the evidence is not amazing, I have to say. It's not very robust. What we do know is that we shouldn't just be doing surgery for infertility if you have endometriosis. Generally, it should be being done because there is a reason to do it in terms of symptoms. Fertility itself shouldn't be the only reason you do surgery. For the most part, there will be exceptions to that. And there are many things that you have to consider when you're deciding whether or not to go through surgery or not if you're wanting fertility. So that might be how severe symptoms are. So sometimes you have to have the surgery because that's the best thing for you in terms of your symptoms. And actually, the fertility has to come second in line in your priority list for that point from that point of view. Also, how long you've been trying to conceive for, what age you are, how many previous surgeries have you had? Is it likely to be a very complicated surgery that might lead to very complex things happening? And how big is the endometrioma, if you have one, in your ovaries? And we don't have good evidence, and I'll come back to this later on, but we don't have good evidence about what size we should be removing and what size we are happy to leave. So essentially, you really need to weigh up the pros and cons, and those pros and cons are going to be different for everybody. It's very much up to you about what your priorities are. So if we look at the balance here, there are going to be some things for having surgery and some things against having surgery. And these are just going to be some of the things you might want to consider. It's certainly not an exhaustive list. But first of all, we know that endometriomas affect how well your ovary works, affect the ovarian reserve, how many eggs are left in there, and maybe can affect egg quality. So that might be a reason that you want to have surgery in order to remove the endometriomas. If you're going to be going down the IVF route, sometimes having surgery actually makes IVF easier. So I will talk about IVF in a little bit more detail, but in brief, when we're doing an egg collection for IVF, we collect the eggs vaginally. So we do a vaginal scan and we pass the needle through the vaginal wall into the ovary. But if your ovaries are stuck in lots of adhesions up at the side of your pelvis, sometimes we can't reach them vaginally. And actually doing surgery in order to mobilize those ovaries, get rid of some of that scar tissue and make them come down where they normally would be placed can make your IVF easier and in fact successful. So sometimes that's a reason to do surgery. Obviously, if you're having surgery in terms of pain relief, that might help make sex easier and therefore getting pregnant easier. But there are other things to consider. So we know on the flip side, if we remove an endometrioma, the whole process of removing endometrioma will naturally involve damaging some of the healthy ovary. So when we strip the cyst out, we will end up damaging some of the ovary, either with our instruments or with the heat that we have to use to stop any bleeding. We know that it can be actually more detrimental to remove an endometrioma than keeping it in. You're all aware that there are lengthy delays at the minute, unfortunately, in terms of endometriosis surgery. And so if you're delaying trying to conceive or delaying fertility treatment until your surgery is done, you could be 2 years down the line. And that could be the difference in terms of your egg number and egg quality of really significantly being detrimental to your chances of conceiving. So if you wait until you're 38 till you're 40 and you've had your surgery at 40, your egg quality and quantity will be significantly affected. And so you may not want to wait for surgery. You may just want to get on and try and start conceiving or go ahead with IVF treatment, whatever the fertility treatment is you need, before you have your surgery. And if you're having particularly complex surgery, if you've had lots of surgery before or you've got very severe disease and there's a complication that occurs, whether there's bowel injury or bladder injury, etc., then the recovery from that may then delay also you trying to conceive. So it's not an easy decision, and it is very much going to be up to an individual person what their preference would be, and we can help with that decision making. But we absolutely appreciate it's not an easy black or white decision for many people. What we do have, though, to help with our decision making these days is something called AMH. AMH is anti-Müllerian hormone, and it is made by the early growing eggs, follicles, which are the little water balloons which contain eggs within the ovary. And it's an indirect measure of your egg reserve, so how many eggs you have left. Now, we can't take your AMH and say, oh, it's 20, you've got 3,600 eggs left in your ovary, but it just gives us a general estimate of what your ovarian reserve is. And it's a very simple blood test for us to do. What we do know about AMH is because your egg numbers fall with age, your AMH falls with age, and this graph on the right shows that. But the graph on the right also shows that there's a huge range of normal. So although most people are going to be between the sort of 25th to 75th centile, there will be other people who are just a bit less than that or a bit more than that. And so having one specific value doesn't necessarily help us hugely, but we know that if you have an AMH of, let's say, 7 when you're 40, that's a fairly good AMH when you're 40, but it would be a disappointing AMH if you're 25. So we have to take the number with knowing that there's an age-related decline with it. We also need to remember, if you look up AMH levels on the internet, we use a different unit than lots of the other studies. So you might find your AMH and actually worry because it's a different, it doesn't look good on the other scale. But so make sure you're looking it up on the correct scale and not getting worried about a result. As I said earlier, we know that if you've got an endometrioma, your ovarian reserve is going to be lower, and so your AMH is going to be lower. And the reason that this is really helpful is that if we can know where you are in this incline of AMH, it can really help us decide whether surgery is actually in your best interests or not from a fertility point of view. And what we do is we have a multidisciplinary meeting about team meeting about the patients that we're worried about fertility, or the patients themselves are worried about fertility. And we can take an AMH before we do any kind of surgery in order to help us make a decision. So, for example, if you have a high AMH and you have an endometrioma that is causing lots of symptoms, you might think, well, actually, it's okay to take the endometrioma out for my symptoms of pain, because actually I've got a good AMH and the chances of me making my ovarian reserve very small are going to be very slim, and you might want to go ahead with surgery. Whereas if you already have a low AMH and you have an endometrioma, we would be very worried about removing the endometrioma and then effectively removing a lot more of your eggs, so you've got very few eggs remaining. And I cannot emphasize enough to you about how individualized this decision making is. We absolutely don't have a one size fits all from this point of view. We take everything into account: somebody's age, how long have they been trying, what surgery might be required, what people's symptoms are like, and what their AMH is. And it's all coming together in we think this is the right way forward, i.e. maybe let's try IVF first before we do any surgery, or no, let's do the surgery first and then we'll sort out the fertility afterwards. So yes, it's all based on one person's specific factors, rather than this is an AMH we shouldn't operate on and this is one we should. Moving on from natural conception to assisted reproduction, you may have heard something called IUI, or intrauterine insemination. And what happens there is that a little plastic thin tube is passed through the cervix, through the neck of the womb, into the cavity of the womb, and sperm is injected directly into the uterine cavity. So we get the sperm as close to the eggs as we can without doing an operation per se. Now, the evidence on whether this is beneficial in endometriosis or not is really pretty uncertain. It may be that if you have minimal or mild disease, a stage 1 or 2, and we give you special drugs to make an egg grow, we may be able to increase your pregnancy rate. It's certainly not a strong recommendation, as it would be called in the guideline. And you could consider it in more severe disease, but actually IVF is much more likely to be successful than IUI, and so we wouldn't recommend going to IUI first before IVF. It's obviously really very much depends on whether your tubes are open or not. We wouldn't want to put the sperm inside the cavity and actually your tubes are blocked, and we've put you through a procedure that wasn't going to work anyway. So there's special tests we can do to check if your tubes are open before you would do that. Now, I have to say, this is not something that we do on the NHS in Edinburgh for endometriosis. They're very small. There's only a very specific couple of reasons that we do IUI. So we don't use it for endometriosis. If you have endometriosis and we think you need assisted reproduction help, then we would just go straight for IVF. And especially because that evidence is just not robust in whether we should use it or not. So IVF itself, this is a little brief summary of it. It's a bit more complicated than how I'm going to explain it, but this is essentially the summary that you need to know for now. In IVF, what we need to do is give you medications that make your ovaries grow more eggs than normal. So at the start of every month, when you're having a normal menstrual cycle, you recruit a little group, a cohort of follicles, which contain the eggs, to start growing. By midway through your cycle, one of those eggs has outstripped the rest in terms of growth, and that's the one that gets ovulated and released. What we're trying to do with IVF is harness that group that we're going to grow and make them all grow to the size that they would ovulate at. And we use medications by injection to do that, and that are daily injections, usually on average for about 2 weeks, to try and stimulate your ovaries to make as many eggs as we can safely. The next thing we need to do is do an egg retrieval, remove those eggs. And as I said, that's done vaginally. Okay, this picture is slightly misleading. We do an ultrasound vaginally, and there's a needle next to the ultrasound probe. Under ultrasound guidance, we put a needle into each of the follicles, which, as I said before, like little water balloons that have an egg inside. We remove the fluid, hopefully remove the egg with the fluid, and then the embryologist collect the eggs for us. On the same day, the male partner will come in and give us a fresh semen analysis, or we thaw out donor sperm if that's what the couple are using. And the embryologists do their special magic in the lab and put the eggs and the sperm together. And we hope then that fertilization will happen. And 5 days later, if everything is going well, we put an embryo back. And that is done, it's kind of like having a smear test. We examine you vaginally, look at the cervix, and pass this thin catheter you can see in this picture here through the cervix into the cavity, and then we essentially inject the embryo inside the cavity. And then we cross our fingers very hard indeed, and that we hope we get a pregnancy test about a week and a half after that. So that, in summary, is how IVF works. In terms of IVF and endometriosis, unfortunately, our success rates with IVF don't seem to be quite as good if you have endometriosis compared to other couples that are needing IVF for other reasons. What we do know is that there's no evidence that taking any kind of medication beforehand, suppressing the ovaries beforehand helps in terms of improving IVF success rates. As I said, there may be a role if you've had surgery to start a medical treatment to stop recurrence before we start the IVF, but just having medical treatment beforehand will not improve success rates. In terms of surgical treatment, we really, again, don't have brilliant evidence for or against. There was a thought process at one time that doing surgery should be done before we do any IVF, but actually we're sort of coming away from that idea at the minute, just purely because the evidence isn't there. The ESHRE, who are our European Society of Human Reproduction and Endocrinology, they produced a guideline on endometriosis, and they said there was no compelling evidence, in quotation marks, that doing surgery for the more severe end of the scale, so the deep infiltrating endometriosis, would improve fertility. But if we're going to do the surgery, that should be to try and make IVF more feasible. So, for example, as I said before, moving the ovaries so we can access them more easily. And that's what I've just said there. So let's talk more specifically about endometriomas and IVF. So, as I'm sure you're aware, the other name for that we know them as chocolate cysts, because that's what they look like when you cut into them. And we do not think now that removing an endometrioma before IVF improves the success rate. So you're just as likely to have a baby if we leave the endometrioma in than if we take it out. And as I've said before, if we do the surgery, it might actually be more detrimental to your ovary than if the endometrioma was left in. However, ovaries with endometriomas inside them do seem to need a bit more persuading to stimulate. So we seem to need to use higher doses of our injections or IVF medication to try and get the ovaries to stimulate well and make as many eggs as we sort of need them to. And sometimes there's some evidence that the egg number that we retrieve from people with endometriomas is a little bit low. However, the good news is that actually, even despite that, the live birth rate, so the success rate of IVF, is essentially similar to those people who don't have endometriomas. The one thing we are quite wary of and cautious of in Edinburgh anyway is we know that if you have an endometrioma and we put the needle inside the endometrioma, there is an increased chance of it getting infected and forming an abscess in your ovary, which obviously can make you very unwell, and we really do worry about. So what we do is try and make sure we don't put the needle into the endometrioma at all. And that may mean that we can't reach all the eggs, okay, if the endometrioma is right in the way, but we counsel people about that during their IVF treatment if we think that might be a possibility. And the other thing we do is give prophylactic antibiotics. You would take a week's course of antibiotics, starting from a couple of days before the egg collection to a few days after, just to try and cover and prevent that from happening. Just another couple of considerations to think about in terms of IVF. There are some of the medications that we use which may cause a flare in endometriosis symptoms. So there's one particular medication that we sometimes use called Prostat, which you may be familiar with, which is often used for sort of long-term suppression of the ovaries and endometriosis pain treatment. We use it not in the long term, but just as a one-off shot, just to help us really control the hormones when we give you the hormones back. So we want your hormones to be suppressed so that we can take control of them. And because it's a short course, that can cause a little bit of a flare in symptoms. It's just something to be aware of. But what's really reassuring is that even though we are giving you treatment that can affect your hormones and make your hormones go quite high, actually IVF doesn't seem to cause a recurrence of endometriosis in any higher rate than it would have happened if you hadn't had IVF. So that's good news. And I said I was going to talk about something called fertility preservation, which is my particular area of interest. And fertility preservation, it's the process whereby we freeze eggs or we freeze embryos. In some cases, we freeze ovarian tissue. That's a very sort of select few people, prior to something happening to someone's ovaries that we know is going to cause infertility. So this was really invented, in inverted commas, for people with cancer. So it's been a couple of decades now that this field sort of arose, and we knew that people who were having treatment for cancer, whether that was some forms of chemotherapy or radiotherapy to the pelvis, that those treatments really affected the ovaries badly. They're really toxic to the eggs, and often these people were going through a very early menopause as a result of their treatment. And fertility preservation gave us a chance to collect eggs and or make embryos before they went through that treatment, so that even if they became infertile after their treatment, they would have those embryos sitting, or eggs sitting in storage for them to use at a future date. It is absolutely not a guarantee that it's going to be successful, but it's our best chance for these people, our best hope for people like this. Now, its role within endometriosis is still debatable. We haven't done it very often. I mean, even globally, we've not really done it very often in endometriosis. And it would be a very specific case that we would choose to do it in. So if we were really worried that somebody was going to lose both of their ovaries during their operation, for example, and were going to be rendered infertile, there would be an argument to do fertility preservation prior to the operation. But we don't know how successful it is. The funding is always a tricky business in terms of will the NHS fund it or not, but it may be indicated in selected cases. And if it is something that we think would be indicated for you, that multidisciplinary team will talk about it and obviously present what we think to you. But it is something that it's not just it has to go through a committee to decide whether that's going to get funded by the NHS or not. But it is something that we are increasingly thinking about for some people. In terms of other things you can do to try and improve your fertility, unfortunately, there's absolutely nothing that we have evidence for. And of course, it seems logical that you would stay healthy in terms of a good diet and doing exercise and everything like that. But we don't have any good evidence that it improves your fertility if you have endometriosis. So things like acupuncture, Chinese medicine, physio, I said exercise, even psychological interventions, they don't seem to have any particular benefit to fertility, but they're not going to be, for the most part, detrimental to fertility. And I mean, a lot of the lack of evidence doesn't mean it's not a true thing. It's just that we don't have the evidence to support it. Very briefly, this was really a talk concentrating on fertility and infertility, but just briefly in terms of pregnancy, when you do become pregnant, I think we're sort of had that traditional view that if you got pregnant, that just makes your endometriosis way better. And we know that's not the case for everybody. So it's certainly not, we wouldn't recommend it as a treatment for your endometriosis to get pregnant. And the other thing is, if you have problems with your tubes, if there's scarring or there's been fluid or blockage in your tubes, there is an increased risk of this thing called ectopic pregnancy, which is a pregnancy that's not in the womb, but elsewhere. So usually in the tubes. So that's just something to be aware of at all as well. So, if signs of that would be having pain usually on one side more than the other of your tummy, rather than sometimes you get crampy pain, but it's usually one side more than the other. Bleeding in early pregnancy is not always a sign of ectopic pregnancy, but it's something that we would be thinking about. So if you have any symptoms in early pregnancy that you're worried about, please do seek help. So in summary, natural conception is absolutely possible if you have endometriosis, and I do want to be reassuring about that. Although it can be more difficult, it is absolutely still possible. Unfortunately, we haven't found any kind of intervention, whether medical or surgical or holistic, that has been proven to improve your fertility if you have endometriosis. But surgery may be indicated in certain cases, and as I said, that is discussed within a whole team of people about whether the pros outweigh the cons from that point of view. If you need IVF, however, the outcomes are reassuring in terms of live birth rates. So although we may get lower egg numbers, even if you have an endometrioma, hopefully it is going to be successful at the same chance as the population without endometriosis. I just wanted to put a few links here to further information for patients who have endometriosis who are concerned about fertility. I'm sure you're all aware of this Expect website. Myself and one of the other doctors, Dr. Skripskati, have written a patient information leaflet about fertility and endometriosis, which essentially covers what's been in this talk today. It's not up on the website yet, but it will be coming. It's going through the sort of approval processes at the minute. If you want to read something just now, if you go to our Royal College of Obs and Gynae website, there is this information about endometriosis. I have to say the section on fertility is very small, but there is a section on it. ESHRE, who I mentioned earlier, they're the European Society of Human Reproduction and Embryology. They are endocrinology, sorry. They have this really quite good information leaflet about women, or anybody with endometriosis. And having concerns about fertility, and you can get that on their website. It's free of charge. And this is not specific to endometriosis, but the Fertility Network UK are a fantastic patient support service, and they run via this website for anybody who is struggling with fertility. And there's a little bit about endometriosis on their website, but in general, it's for people in general who are struggling with conceiving, and they're absolutely fantastic if you're looking for extra support from a patient support network. So thank you very much all for listening. I hope that was helpful, and I'm happy to take any questions.